Hi friends, Pradeep Pendyala. Today I am going to talk about ARDS. Yes, friends, it's very interesting. Acute respiratory distress syndrome is very interesting syndrome, and everybody should know, especially the anesthetic management and mechanical ventilation is other thing. I'm mainly going to talk about the anesthetic implications and a little bit about what it is all about. As you are aware, direct lung injury can cause ARDS or indirect lung injury. The most important factor which can cause indirectly ARDS is sepsis and massive transfusion of blood, more than 6 units. Acute pancreatitis and multisystem trauma, cardiopulmonary bypass or fat emboli are other indirect lung injury factors. Direct injury can also cause ARDS like aspiration of gastric contents, pulmonary contusion, diffuse pulmonary infections, bacterial, fungal or viral pneumocystis or inhalation injury or after drowning. So, what could be the pathogenesis? Common to all inciting risk factors in an intense inflammatory pulmonary reaction which could develop as a result of injury to the alveolar epithelial and endothelial membranes, flooding the alveolar space with the proteinaceous exudative contents, and also there will be large amount of collection of neutrophils around it. This could cause shunting and altered gas exchange. So, tidal volumes, when you are managing it, one thing I can never forget is the concept of protective mechanical ventilation is most paramount, including the use of low tidal volume to minimize barotrauma and lung injury and maintain low plateau pressure. What is this plateau pressure? I'm sure some of you might be knowing. Plateau pressure is the pressure that is applied by the mechanical ventilator to the small airways and alveoli. The plateau pressure is measured at end inspiration with an inspiratory hold maneuver on the mechanical ventilator, that is 0.5 to 1 second. Friends, as I had mentioned, we need to use protective mechanical ventilation with low tidal volume to minimize barotrauma and lung injury in the case of ARDS. And the draining pressure with moderate levels of PEEP is permitted. The use of recruitment maneuvers has gained particular attention, showing positive effects on the PPC. PPC is postoperative pulmonary complication as well as improvement in ARDS patient. Well, friends, usually we give around 6 ml per kg for predicted body weight. However, tidal volume as low as 4 to 5 ml could be preferable in an adequate gas exchange if an adequate gas exchange is ensured. It does not increase the risk of atelectasis. So, in fact, some people advocate more amount of decrease in this tidal volume, and it's been found that it's very useful. Like when you compare 4 to 6 ml per kg or 8 to 10 ml per kg per body weight, keeping in view the plateau pressure below 21 centimeter of water, it found no benefit from lower tidal volume in terms of ventilator free days or hospital stay and mortality in critically ill patients without ARDS. Nonetheless, tidal volume is considered the main determinant of ventilator-induced lung injury and should be targeted to maintain plateau pressure of less than 30 centimeter of water, and low driving pressure should be less than 15 centimeter of water. That is it. And as far as inspired fraction of oxygen is concerned, inspired fraction of oxygen should aim to maintain a SpO2 between 88 to 95% in ARDS and above 92% when there is a risk of ARDS in surgical patients. So be careful to avoid hyperoxia, especially in the patients who are at risk of developing ARDS intraoperatively or postoperatively and with potential detrimental effects on alveolar damage. The hyperoxia, what will it cause? It will cause alveolar damage, endothelial inflammation, and mitochondrial dysfunction through increasing oxidative stress and direct lung injury. So, during surgery, hypoxemia can develop and FiO2 should be increased, followed by increase in PEEP and then stepwise recruitment maneuvers. However, high oxygen levels during surgery can cause high risk of major respiratory complication, as I had just mentioned. So, you need to do PEEP titration, especially in patients with or at risk of ARDS undergoing emergency surgery. Whenever you are doing any surgery for ARDS patients, it has to be only for emergency surgeries. So, level of PEEP is another relevant component of lung protective ventilation. In patients with ARDS undergoing surgery, PEEP choice should be guided by the ARDS level. As I mentioned, low tidal volume of 6 to 8 ml or still low is better, and low PEEP, even to the extent of 2 centimeter water, reduce the risk of developing PPC. As I had mentioned, PP is nothing but post-operative pulmonary complication and of hemodynamic impairment. No strategy of PEEP titration can be followed unless you are doing titrating doses. And recommended thing, highest level when you reach is PEEP not more than 15 centimeter with moderate to severe ARDS and as a rescue strategy. Otherwise, as I said, should be much less. And when there is a problem with PEEP causing hemodynamic impairment, vasoactive drugs or more fluids are needed. At the same time, you have to be very careful because extra water, extra fluid can worsen the lung function ARDS patient. So you have to be very careful, and restricted fluid supplements should be given, preferably vasoactive drugs. It's better to maintain MAP of around 65 or more. Therefore, PEEP should be considered as a tool to maintain oxygenation between 88 to 95%. And as I had mentioned, minimal PEEP level ensuring adequate gas exchange in all patients undergoing emergency surgery. The higher PEEP levels can be used only as a rescue therapy. And a word about recruitment maneuver. Recruitment maneuvers have received a lot of importance, especially in alveolar recruitment of ARDS trials, known as ART, comparing lung recruitment and titrated positive end expiratory pressure compared with low PEEP in patients with ARDS. So, as I had mentioned, tidal volume reduction is very important, and especially during laparoscopic surgery or alveolar recruitment maneuvers by positive end expiratory pressure, improved lung function and reduced postoperative pain. So, we have to select PEEP accordingly, and as I have said, ARDS with increased extravascular lung water level and mortality, especially when fluid overload is being given or more blood products transfusion, can cause further increase the risk of ARDS and worsen endothelial lung damage. So a restrictive fluid strategy should be therefore followed. That's very important. And preferably MAP to be maintained more than 65 to 70 millimeter of mercury. And definitely it's very challenging when you deal with ARDS patients because invariably they have systemic inflammation, and that can occur due to direct negative effect of cardiac contractility and function, and that can result left ventricular impairment. Right failure is very common in ARDS patient, and function could be further impaired by the application of mechanical ventilation with high PEEP. So whenever you are giving PEEP, you must always remember that it is working on intrathoracic pressure, and it can cause reduced preload. Moreover, right heart dilation could impair left ventricular filling and preload. So, and left ventricular dysfunction further increase pulmonary capillary hydrostatic pressure and subsequent extravascular lung water extravasation. So we need to give adequate vasoconstrictors or inotropes administration for ARDS patients who have hemodynamic impairment. And regarding pulmonary artery catheter, is actually gold standard, but its use and presently in ICU has dramatically decreased over the last decades. Even in operation room, it has a very limited usage, PAC, pulmonary artery catheter. And the best part is modern minimally invasive monitoring has taken over this. It has replaced PAC. How? The basic monitoring requires an arterial line, while more critical patients might benefit from non-calibrated or calibrated pulse contours, which can estimate easily cardiac output and vascular resistance. And in few cases, chest ultrasound can be very helpful to investigate lungs as well as cardiac function. So this way, non-invasive method of management ARDS is good enough rather than using PAC. I hope this talk was very useful and informative to some extent if you have not already been introduced with ARDS. Until next time, take care. Goodbye. I am Colonel Pradeep Pindiala, Professor of Anesthesiology. Once again, friends, today is Baisakhi or Bihu also. And for Tamil Nadu people, it's a new year. So wish you all the best for happy Baisakhi, happy Bihu, and happy New Year for Tamil Nadu people. Thanks. Thanks for patient listening. Bye-bye. Take care.